Good evening, everybody, and welcome to this International AIDS Society Love Yourself media briefing on the impact of COVID-19 in Southeast Asia, and in particular the impact on HIV. I'm delighted to welcome today our esteemed group of speakers and also those journalists who have joined us today. I also understand that we have quite a large group of people from civil society and community sitting in on the call too, so warm welcome to all of you as well. Before we get started today, I just wanted to go through a bit of housekeeping on the logistics of today's event. We are going to hear from all of our speakers for about 5 to 7 minutes today, and then we're going to open it up to questions from you, the journalists. After when you want to ask a question, please use the chat box and write your question. Please do indicate which media outlet you're from and from which country, and please do indicate also who you want the question asked of. Please make the question short and direct, please, so we can get through the questions. We had a media briefing yesterday and we had a lot of questions, so the quicker we can get through them, the better. The session today, the media briefing, is being broadcast live, and we are also making a recording of it. We will send you the link to the recording a few hours after the event is finished, a quarter to the hour today. I will say that the comments in this media briefing are all on the record, unless one of the speakers indicates otherwise. So you can take it as a given that everything that you hear in the session today is quotable for broadcast, print or online as well. That's the housekeeping out of the way. I would just like to make a few introductory remarks to set the context and set the scene for today's media briefing before I hand it over to our speakers. Just very, very quickly, we're holding this event principally because the IAS and its International Education Fund are holding a parallel meeting at the moment, which was meant to be in Manila in the Philippines, but is of course being held virtually. The reason for this meeting is it joins a series of meetings that the Education Fund holds around the world in a parallel, often with AIDS conferences or national AIDS conferences, to promote collaboration between researchers and scientists and practitioners on the latest trends around the HIV/AIDS epidemic in particular countries and particular regions. And obviously, in this case, we're looking at this region of Southeast Asia. So a lot of the speakers you heard from yesterday and from today are speaking primarily to what they addressed in the symposium over the past few days. We also, in terms of context, of course, everybody here will be aware that tomorrow, June 5th, is the 40th anniversary of the first notification of an AIDS case in the United States. So that certainly sets the context in terms of looking back and seeing where we've come and where we may be going to as well. And of course, that happens a few days before next week's United Nations high-level meeting on HIV/AIDS, which also marks 20 years since the United Nations special session on AIDS that was held in 2001. And I would just like to remark that that meeting was incredibly significant, as many of you will be aware, for the momentum it provided in terms of getting antiretroviral drugs out to the sub-Saharan continent of Africa and also to Southeast Asia, to Asia in general, when beforehand there was a major issue around those drugs actually leaving the wealthier countries. That UN meeting led to the development and the creation of the Global Fund against AIDS, TB and malaria, and also drove some of the momentum to the development of the PEPFAR Fund, the Presidential AIDS Fund in the United States, set up by then President George W. Bush, and of course, the one and only Dr. Tony Fauci. So there's lots of context for this meeting, obviously. Just before I introduce Adiba, very, very quickly, you'll see behind me in the background the IS logo, but also HIV Unmuted. Just to let you know that to commemorate the 40th anniversary this year of HIV/AIDS, the IS is putting together a 15-series podcast. The first episode is already run and features Dr. Tony Fauci talking about the very, very early days of the pandemic in the United States. It's a fantastic listen, and I encourage anybody who's got 25 minutes spare to listen to the first episode and follow it throughout the year. There'll be a lot of big names appearing on it, a lot of fantastic HIV activists will be on it, and a lot of well-known scientists, doctors, and researchers as well. PR out of the way, I would now like to introduce our first speaker, who needs no introduction. Our first speaker is Adiba Kamarul-Zaman, who is, as you probably all know, the president of the International AIDS Society, and she's also a professor of infectious diseases at the University of Malaya in Malaysia. And many of you will also know Adiba as a champion of HIV for many, many years, and harm reduction as well. But also many of you will be aware that Adiba has been quite prominent in the response to COVID happening in Malaysia at the present time. So without further ado, I'll hand it over to Adiba. Over to you, Adiba.
Thanks, Michael, and good afternoon, friends. Nitya, Ching Siong, Bin, Ayu, and Mike, and all media who's present this afternoon. Thanks for joining us, and we hope that this will be a lively, interactive session. I'm just going to say a few words about the COVID-19 and its impact on HIV in Malaysia. I think our region at the moment is experiencing surges in many of our respective countries after, really compared to Europe and UK and the US, we were doing relatively well, but it seems unfortunately to be our turn at the moment. And certainly in Malaysia, after a good, I guess, 2/3 of 2020, we were doing well. We now are struggling to contain the pandemic. Just looking at today's figure, and it's 7,748 newly reported cases. We've exceeded 600,000 cumulative number of cases since the first report in January of last year, and we're consistently reporting more than 100 deaths a day. So the situation in Malaysia is very worrying. As Michael mentioned, not only do HIV, but I've been working in the COVID response, including looking after patients at my hospital. And, we've been experiencing a lot of tension in terms of trying to open more wards and beds, particularly intensive care facilities for patients, not just at my hospital, but all over Malaysia, of course. The pattern of the pandemic, originally was imported cases. We managed to control it after a massive religious cluster, mass gathering. We were quiet for many, many months until an election took place, and also, just like in Singapore, we've been experiencing many clusters of infections from dormitories and factories. And more recently, the spillover to the community has been exacerbated by the Ramadan month, where traditionally there's a lot of congregation and prayers and visiting to families, etc. So that's where the infections have been coming from, and we, just gone into another. Well, it's supposed to be a total lockdown, but it doesn't seem to be as strict as the very first one that we had in early last year. And it's supposed to last 14 days. I think we've had 6 days of it, so we'll see. The numbers seem to have stabilized a bit, but it's nowhere near, I think, where we want it to be to safely open up again. Our rollout, I guess, aside from the lockdown and ramping up testing, we will obviously need to roll out vaccination program like everyone else in the region. I think we now have only managed to vaccinate about 6% of the desired population. The the challenge is, of course, always the supply, in getting enough supply, but also in dealing with hesitancy, dealing with rural areas, etc., etc. But this has been a major focus in the last few weeks to try and get the vaccine out. We're currently using Pfizer, AstraZeneca, and Sinovac, and I think there are attempts by various people to bring other vaccines in as well to complement and supplement what the national government is doing. In terms of the COVID-19 impact on HIV, I think just like with everywhere else, the initial lockdown, heavily impacted HIV, people coming forward for HIV testing, not just for the logistics, because the clinics were shut, you can't travel outside of your immediate zones and areas, but also I think people were genuinely afraid to come forward to be tested, and in case they might contract HIV from healthcare settings. So we saw a decline in HIV testing, but kudos to our community partners who stepped up the HIV self-testing facilities, and also our outreach workers in particular, who are doing the needle syringe program, who found ways to still continue to reach out to their clients with clean needles and syringes throughout this period. Nonetheless, there have been disruptions to, as I said, testing and service delivery, particularly for harm reduction. In terms of ART, I think clinics were pretty quick to respond by putting in telemedicine as well as multi-month dispensing. And so I think the disruption to ARVs was not as severe as it could have been. So perhaps, Michael, I'll stop there for now, because we'd also like to hear from others of their experience with both COVID and the impact of COVID on HIV in their respective countries. So thank you.
Thanks, Adiba. Our next speaker is Nitya Far. She's an IS Governing Council member and also Executive Director at the Institute of HIV Research and Innovation in Bangkok in Thailand. And we've got Nitya to talk about what the situation, the evolving situation is around COVID in Thailand. Over to you, Nitya.
Thank you, Michael, and thank you, Adiba, for laying out the situations in Malaysia, which is, I would say, quite similar in terms of the cases and responses to what we have had in Thailand. For us in Thailand, I think what COVID-19 has brought to us quite obviously is the not inequity, disparity in valuing healthcare providers in our country. What we have seen quite clearly since the start of the epidemic regarding the provision of PPE and now the provision of vaccine has been made mainly for healthcare providers who are conventional healthcare providers. And I think all of us working in the HIV field, we know that we have worked so closely with our providers in the community. So those who are community healthcare providers are those who are left out since the beginning of the pandemic in terms of getting enough supply of PPE, and now in terms of being prioritized for vaccination. We have had our lay providers in the communities throughout the country, especially in Bangkok, which is now the red list area in the country, who found it really hard to get access to COVID vaccination. Even like we have to bake around to get the vaccine to our community healthcare providers, and we still haven't yet been successful in doing so. And the next thing related to vaccine, I would say here, because now we know that we may have been dealing with acute phases of COVID-19 in getting people to be alive, to get access to hospital beds, to get access to COVID testing among those who are people under investigations, etc., etc. And now I think that it's so difficult to work when we are in the situation of this vaccine uncertainties. I would not say like vaccine hesitancy, because it's vaccine uncertainty in every aspect of the vaccine. So it's not like Adiba mentioned, it's not only not enough amount of vaccine, but it's also vaccine hesitancy in general, and then vaccine hesitancy among certain populations, like among people living with HIV, among people who are taking PrEP and PEP, among people who are transgender women who are taking gender affirming hormones, among people who use or who inject drugs, for example, that I think we have worked quite hard over the past few weeks, hoping that we will have enough vaccine to start the actual rollout in the coming weeks in Thailand. And we have to say that it is quite challenging to address those concerns raised by these armchair professors, armchair epidemiologists who continue to provide this confused information in social media. For example, for us in Thailand, we have Sinovac as our main vaccine. And one day people got this immune vaccine induced vasoconstriction, and then a professor said that okay, everyone has to stop taking migraine medication, etc., etc. And then a few days later, the Royal College of Neurologists will have to come out to say something. And last week, a person taking contraceptive pills had this pulmonary embolism, and then a few days later, the Royal College of OB/GYN will have to come out to say that. And I think this is like what we really need to it's hard work already, and then now within this era, everyone can say something, and once you are a professor, you seem very much reliable. And then the next thing is those very much related to the burden of health services. You know, during the first two waves, I think many of us just like stop working, right? Or just like makeshift among our staff, have half of our staff providing the service, and get and make sure we can provide at least half of the amount of clients that usually will coming in. But right now, I think in this wave, we don't see the end of the wave. So I think everyone is doing things as usual. And we now say that, okay, it's universal precaution. So you don't have to wait until you get something, or you are sure that someone is free from COVID that you can serve them. You have to do so. And then because of this like huge wave coming in, it's like an overstretched cadre of healthcare providers now having to also keep providing HIV and sexual health services, while also having to deal with livelihood support and COVID related health support for those who are vulnerable to both HIV and COVID-19. And now we are seeing COVID-19 epidemic mainly among urban poor settings in Bangkok, and there are a lot of migrant workers within this setting as well. And then lastly is that although I think we have tried hard to use innovations in trying to continue providing the services to the remaining high number of clients coming in for HIV and sexual health service, using telehealth, using express service, using MMD. But I mean, although we are praised, like when we talked in a forum like this, that okay, HIV people, they use this like innovation, adapt themselves very well. But I don't see a very certain support from the government, from MOPH, to say that okay, they approve this, they support this, and these services will be reimbursed. You know, it's just like everyone feel that it will end soon, and this will be just like temporary measures that if you can do it, you just do it. I'm not saying that I will reimburse the cost to you, yeah, something like that. So I think that's probably all from Thailand for the updates, and I'm happy to get questions during discussion.
Right, thank you, Nitya. That actually kind of, I think, while you were speaking there, I was thinking about the recent Lancet piece that came out, which compared countries who decided to eliminate COVID and those who decided to mitigate it. And Singapore was one of those countries, Australia, New Zealand, Taiwan, South Korea. And the common thing they all had was that they followed the science. They often had their key scientists up on the podium every day talking to the community. But they also have political leadership, which is interesting too. And as you say, in this day and age with online, a lot of science gets floated around as well. And a lot of bad science is also in the ether too, that is mudding the waters in terms of where people are getting information. But it's true to say that the countries that have done well in COVID so far have generally emphasised the role that science needs to play in the response and following good science and understanding the pandemic. Moving on to our third speaker. Our third speaker is Vin Paktakan, who is the Executive Director and founder of Love Yourself, which is a wonderful NGO working with the LGBT community, MSM community, positive community in the Philippines. And Vin is going to give us a bit of a perspective on where COVID-19 is in the Philippines at the moment and the impact on HIV as well. Over to you, Vin.
Hi, Michael. Hi, everyone. Good afternoon. I am Vin Pagtakan. You can just call me Vin, and I am from Love Yourself. So I'll share a little bit about what's happening in the Philippines. Just like any country right now, we're experiencing a lot of challenges here in the Philippines. It's been a very big whirlwind in the past 3 months because there was a sudden uprise of cases when the British strain came in the Philippines, and the cases tripled. And the Philippines had to get and have a forced enhanced community quarantine lockdown for 2 months. And then eventually, I think last month, we started to, relax a little bit since the cases went down a little bit. And vaccine rollouts started with frontliners, medical professionals, and then the senior citizens. And then I think this month, last month, middle of May, we started the vaccination programs for some cities for people with comorbidities. And we're happy to share because we have a partnership because in the Philippines, the design is each city will conduct its own program for the vaccination rollout. And we're very lucky we're in one of the cities who partnered with us and allowed us to have the training for the vaccination. And we were able to vaccinate all our 7,000 clients who are living with HIV. So they allowed us to borrow a school. And that's for 1 week. And then we actually had another set just last week for 2 days to assist our clients and our partners and the other humanitarian volunteers who are doing interventions for HIV to be vaccinated, because it's really risky right now. We can't do any outreach work. In terms of the cases in the Philippines, yesterday and today, there were 7,450 reported cases, totaling to 60,794 cases in the Philippines. So those are the current cases right now. And side by side, the Philippines is doing its rollout of its vaccination. I think this month, June, we will start rolling out the vaccination for what we call the A4 classification in the Philippines, which are economic frontliners. Some cities are still catching up. They're still in their A2 and A3, which are people with comorbidities and senior citizens. But the mega cities are starting their A4 this month, which are the economic frontliners. We're very happy because it started, but we want to have a campaign. If there's something that we want to do here in the Philippines, is that a campaign more on vaccine promotion and awareness, because there's a very high I mean, these are anecdotal, but the people from the ultra poor sections of the community have high vaccine resistance, because in the past, I think 4 or 5 years, there was an issue of the dengue vaccine here in the Philippines. So the most parents and people in the barangays, in the localities, in the suburban areas are still, a bit anxious about that scenario, and there's still, backlash from then. So we hope to promote vaccine awareness, its safety, because the available vaccines here in the Philippines are only Sinovac and AstraZeneca since January, and I think Pfizer and Sputnik just came in last week of May. And there has been a lot of drama surrounding the Pfizer vaccine, because people want the brand. Because the politics of the vaccines and all of those. I just want, hopefully, we can just remove all of those politics and just promote vaccines as they are. Vaccines work. So, anyways, that's the scenario of COVID here in the Philippines. It's still strict. We still have curfews, and we're still wearing face masks and face shields to protect ourselves. That's very good. And many people, the Filipinos are very compliant, but of course, some people, we still have poor awareness. They still have issues. On the end of our HIV program, we have a total of 83,000 cases since 1984, and last April is our latest report. We have 1,020 cases reported, for which it's like 33 persons a day, 96% of which are men, and 1% of that 96% are transgender women. So majority of the cases, 58% of the cases are in the National Capital Region, plus the two surrounding regions, which is Region 4A and Region 3. So basically, we call them NCR+, which is also the main focus of COVID. We call it the NCR+ bubble. So 58% of the cases are there. And also COVID, majority of the cases are in the NCR+ bubble. Now, just like what Dr. Nitaya mentioned a while ago, we have been innovating a lot. And we started with doing bookings. So everything's telemedicine, express refill, delivery, couriers. Even our laboratories, we just do extraction at their homes and then collect them and then bring it to our community centers and process them for viral load, CD4 baselines. For PrEP clients, we go to the client's house for the extraction of the initial baseline laboratory tests. So those are the things that we have been doing. And just like what Dr. Nitaya says, I hope the government sees and find a more long-term solution for this, because we're covering all the costs and it's not very sustainable right now. I mean, it's good that the organizations are able to adapt, but everyone needs to adapt, and we need to find a way to sustain these programs through creation of guidelines, protocols, so that things can, because COVID will not leave us very soon. So hopefully we can find ways to make sure that the services will continue, and those people who are poor and cannot afford can access the services continuously. So those are the things that we have been doing in the past year and a half. And we're doing activities together with Global Fund, Filipina Shell Foundation, USAID, and EPIC for for us to be able to expand all of the programs that we have to all over the Philippines. So we're supporting around 17 community-based organizations all over the Philippines and replicating the services that I've mentioned a while ago. So those are the updates that we have here in the Philippines. Hopefully, this COVID situation that we have, hopefully we get the herd immunity that we need so that things go back to the way it used to be. Thank you so much, Michael. Over to you.
Thanks, Ben. Thanks, Ben. That was really, really insightful and very, very informative. And I'm sure will generate a number of questions from the media as well. Our next speaker is from Indonesia. She is Ayu Octaviani. Ayu is living with HIV and is an activist based in Indonesia. And she's here to talk about the situation around COVID-19 in Indonesia and what that means for HIV going forward. Thanks, Ayu.
Okay, thank you, Michael. So, hi everyone, and also all the journalists and the media person. So, a little bit update in Indonesia that the progress is actually not the progress. The situation it's still high in Indonesia. Even it's 1 year already. Until now, the number of cases is the whole number of cases is 1,800,000 something. But thank God that the Ministry of Health provide us with the access of healthcare. They're very good that we have, the access of healthcare. If we get COVID, is all free. So there's, the main hospital in every province that provide by the government. So once you got the COVID, they make sure that you're not getting poor because all the healthcare is not cheap, right? But the rules in the government isn't clear enough about the traveling, about the lockdown, and it makes the number of cases is going up and down, especially when I'm not sure Adibais mentioned about Ramadan. After the Ramadan, the in Indonesia is very the country with the cultural. After the Ramadan, all the family will going back to the hometown and everything. But
Lebaran.
the Lebaran, the situation is very difficult because even the government make the rule about the traveling is very strict. Still, people will cheat and everything. It makes the number of cases is up and down. But what I want to stressing is what I see is my country is when there is a new disease like COVID is let's say control the country. Somehow I feel like they forgot about what is important before. Like not only I'm not talking about HIV, but HIV and TB and all another disease. So they now focus on COVID. Of course, it's more urgent and important right now. But what I see it's very scary is at the beginning of the COVID pandemic last year, the pandemic make, I don't know, I think they miscalculation about the stock of the ARV in my country, and that makes I remember we struggling around 3 until 4 months that we have stock out of the ARV. It's very scary because we still import the raw material of the ARV from India, and as we know, India is locked down. How can we make the send the raw material of ARV that we already produce in here? We cannot use the the plane even. So the strategy to recover the stock out situation is very slow because everyone, the government, especially in the Ministry of Health, focusing on COVID. And then luckily it's recover after 4 and 5 months at the beginning, especially in some regimen. They are struggling with, every people living with HIV should borrow each other, medicine. And I think it's difficult for us because everyone need the medicine. We cannot borrow from anyone. So I think every country should have really good management if we face another new disease, and then we're not gonna left another disease behind. And also the COVID-19 makes, the hospital become, the house of COVID. Yeah, the all the patient will go to the main hospital, and mostly all people living with HIV also have to go there. When the COVID is start, we have very limited access to go to hospital. But if the people living with HIV who already in a good situation, it's very easy for us because there's people from the community who work as an outreach worker, etc. They will help us to deliver our medicine. But if the people living with HIV who still, on the face of AIDS, and then they face another needs like, the PMTCT access, or they have to do another healthcare access, it's very, very limited because, we are not allowed to go to the hospital. But the scariest thing that I felt is from the perspective of women, that after the COVID-19, the number of violence against women, especially women living with HIV in domestic level, is increased. It's mentioned in the yearly report of Women Commission last 2020 that the number is increased 4 times than before, that women living with HIV got, violence because, we all stay at home. We are work from home, school from home, so there are no protection. And Indonesia is not ready yet for, helping the situation of women living with HIV who facing the violence against women. So luckily, in my organization, Indonesian Positive Women Network, who also working with the another women movement in Indonesia who are working for violence against women, we are now trying to integrate, the service between the violence against women and the HIV service. So they have to know that it really connect to each other, and it's like seeing the which one first, the chicken or the egg, because the women get more violence because of the HIV issue, and the women who got sexual violence also can get HIV because of that. And the COVID pandemic increased the number of the violence. I think that's all, the situation, and then the impact for the in the HIV situation. Sorry that my English is very complicated, but I think that's all, Michael, that I can update. Thank you, Adiba. That's all, Michael. Thank you.
Thank you, Ayu. Your English is perfect. I don't know, I wouldn't be critical of your English at all. Thank you for that. That was really, really interesting. I'm sure it's actually got me thinking about a question which I'd like to ask of all the panelists, actually, if we get time today. I see that there are questions coming in from a number of journalists, so we'll get to those after we hear from our last speaker, who is Dr. Wong, who is Deputy Director of the National HIV Program at the National Centre for Infectious Diseases in Singapore. Over to you, Dr. Wong.
Thanks very much, Michael. And thanks for inviting me here. And it's really nice to see old friends in the room as well. So I think, similarly to the other speakers, I'll just talk a little bit about what the situation with COVID is like in Singapore, and then specifically how it relates to HIV. We had our first case of COVID infection in January 23rd last year. It does seem like a lifetime ago now. And to date, we've had about 62,145 cases correct as of yesterday. As I think Deepa and Michael sort of pointed out, Singapore has, from the beginning and up till today, maintained a very strict stance on containment. And it's taken what the government has called a whole nation approach. So it's on every front: economic, education, healthcare, foreign policy, home policy, and there is still, our borders closed in phases. They're not completely closed, obviously, but through management of the borders and through a process of rigorous sort of testing, screening, contact tracing, quarantine, and treatment, I think we have managed to keep numbers and definitely mortality at a low level. Similarly to what's being experienced in Malaysia and I think in Thailand now, our major wave last year in the first half of 2020 came from migrant workers. Thankfully, that has quietened down. And I think one of the things, if we were to take a silver lining approach to looking at this whole situation, is that it has really forced all of us to look at what the weak links are and what really can be improved and what systems can be revised. And I think one of the things that I feel has really improved is the welfare and protections of especially vulnerable individuals, such as migrant workers who live in crowded dormitories, for example. In terms of vaccination, we started a national vaccination program. The first shot in arms went in on the 30th of December last year, and since then it's been rolled out in phases. So we started off with vaccinating the most vulnerable, and in our setting, these were the elderly people. As of last week, I think about 3/4 of all individuals aged 65 and above have had at least one dose. Nationwide, about 40% of people have received at least the first dose of their vaccine. And we have started with the mRNA vaccine, so the Pfizer and the Moderna ones, although we are starting to sort of look at other vaccines as well. In terms of the social, what it's like sort of on the ground, we went through what was called a circuit breaker period last year, which was when our cases were quite high and the government decided that we should impose what is essentially a lockdown for a short period of time. And then since then, we've actually opened up in phases. With our most recent in the last 5 or 6 weeks or so, because cases have started going up, probably because of the importation of variants, we've gone sort of one step back, but still, generally speaking, we are trying as much as we can to live life as normal. Right now, we are in a period of 2 weeks or so where we can't dine out. That's been a bit challenging because we've been able to enjoy that for a while now. So all of us are but I think the general consensus is that we know what's the end goal, hopefully. Although, like everyone here has said, we are realizing that there's no easy end to this, and it's about finding a new way to live. Specifically with regards to HIV, I think in Singapore, we've got about 8,800 people living with HIV who have been diagnosed with HIV since the beginning of the epidemic, of whom about 6,800 or so are still alive and with us today. I work at the National Center for Infectious Diseases, which is the largest center providing care for people living with HIV. We see about 4,500 patients in our center. And unfortunately, as the National Referral Center for Emerging Infectious Diseases as well, when the outbreak broke out, we had to sort of scramble and find a way to function that was safe for our patients first and foremost, but also took into account the fact that manpower took a hit, right? Because I think as infectious diseases physicians, we provide care for people living with HIV. And in Singapore, at least, HIV care is still fairly centralized in specialist centers. We hope to be able to move towards a model where there's more community-based care. But as it stands, and when 2020 came around, we were still very specialist-centered. And yet, as as Vin pointed out and as Ayu pointed out, many of the hospitals and infectious disease centers were also where COVID was focused and centered. So we've had to sort of scramble. I think as many of my fellow speakers have said, we've pivoted around to telehealth, which is a government-led initiative. But as a physician, I think my challenge is always, while I've been trying to design all these workflows which keep patients at home, at the end of the day, I really have to ask myself, HIV care has always been I tell my patients, I will start this journey with you and hopefully I'll walk the entire journey with you. And yet I haven't seen some of my patients for close to a year and a half, short of a phone call or a text message and so on. And there are true concerns, both my personal as well as with my colleagues, about whether or not the quality of care is being affected. Of course, we're stuck between a rock and a hard place. I looked at some data, just to see whether there was a reduction in, or rather a loss of viral suppression control. Thankfully, when we compared 2019 and 2020 in our center, the rates of viral suppression remained exactly the same, so that's great. But testing has taken a hit, and compared to 2019, the number of HIV tests done nationally have dropped by about 30%. The number of new diagnoses reported to the registry have dropped by about 20%, and some analysis has shown that at least, I don't think we are picking up less because we are testing less, proportions wise at least, but definitely this is something that we're keeping an eye on. People living with HIV in Singapore can get vaccinated, and we fought very hard to get people living with HIV vaccinated a little bit early. Uptake has been fairly good as well. But I think my main view on how it's affected HIV is just in the model of care that we have had, and going forward, if keeping people out of healthcare institutions as much as possible, because they are still being used to care for people with COVID infection, is going to stay with us in the long term, then it's really forcing us to take a long, good, hard look at how our care infrastructures are designed, and how we can continue to provide HIV care that has that person-centered touch, but also that personal touch, while still being safe. Yeah, I think that's about it. It's been a challenging time, but I think all of us have learned and grown from it. Thanks so much.
Great, thank you very much, Dr. Wong. So that concludes all our speakers. I'll start off now with some questions. I have two questions from Rita Wilyadana, who is the health reporter at the Jakarta Post in Indonesia. And the two questions I'm going to combine, they're addressed to Dr. Adiba, but other people might want to chime in afterwards as well. And I hope I've got this right, Rita, but I think Rita's kind of maybe asking Adiba if you can see examples of where perhaps HIV programs are being sidelined due to the COVID pandemic. Like, are there specific examples? Like, is there less testing, are there less services, etc.? And what do you see going forward in terms of the ongoing impact of COVID on HIV programs, outreach, and infections going forward, specifically in Malaysia?
Yeah, so in Malaysia, fortunately, we have not specifically had programs stopped, thankfully. And also thanks to the Ministry of Health, the funding has not been reduced. I mean, we asked for a bigger budget, but we got the same as last year. So there's not been a cut, which I think in this climate, it's something we should be a little bit thankful for. So the program impact on a sort of a national level, we've not had it too bad, but like what I mentioned earlier, in terms of at the individual level and maybe at the smaller sub-district kind of level, it's more the practicalities that COVID posed a challenge. It's not so much a policy or unlike our colleagues in Indonesia who had a stock out, we didn't really experience that.
Great.
I don't know if Nitya, did you have any of that
Yeah.
in Bangkok?
Yeah, I also would say that I mean, I don't think if we do not intentionally reduce our own service, I think all healthcare providers, especially those in communities, are more than ready to like give their 200% effort in trying to continue the same level of service. But at the same time, I also have experienced over this last wave after our Songkran holiday in April, that because the people working in the community for HIV, they are so much into this client-centered approach in every health condition management. So we have seen and we have been part of these communities rising up to use the community-led approach for COVID-19 response, you know, because many of you may work in the hospitals and you like see people come into the hospital, but we work in the communities and we experience people in the communities who cannot get access to testing, who cannot be linked to care, for example. And it's when you say client-centered approach, it's more of the holistic approach. You're not dealing with just clinical concerns about COVID-19. So not just lung symptoms, etc., but it's mental health, it's stigma discrimination, it's how people are violated their rights, but how their rights are violated during this time. So I think this also has like get some of the efforts or times from our healthcare providers into trying to deal with COVID in the aspects that many other people in the hospital may not have time to do, you know. So like in April, we may say that 100% of our time are actually not doing much of HIV and sexual health service, but more on COVID. But now we are getting into a more settled way of how to balance our COVID work and HIV and sexual health work. So it may be like 70%, 30%, something like that. Yeah.
Great. Thanks for that, Nitya. I have another question here for Dr. Deba. It's from Milad at the Malay Mail. It's a bit similar to Rita's question, but it's asking a bit more specific data. So the big question, Adeba, is from Milad is, how will the pandemic affect the long-term efforts to end AIDS in Malaysia by 2030? We're all trying to end HIV/AIDS by 2030 around the world, but how do you see that playing out if you have a crystal ball? And we've seen a decline in testing in the country during the pandemic. Okay, so his second question is, we saw a decline in HIV testing in the initial lockdown last year. Are we seeing that happening again during the current lockdown? Or is it too early to tell?
Yeah, thanks, Mila, for those great questions. Just very quickly, I think on the testing, it is a bit early to tell, and we need to do a second round of survey to find out about that. The quick answer would be, I think the longer the pandemic drags on and continues, obviously the riskier it is for other non-COVID related conditions, including HIV. Firstly, because you know, the budget will probably need to be reduced because all economies, all national economies are going to be heavily affected the longer it goes. Secondly, the attention. I mean, I think globally already the attention has, squarely shifted towards COVID, and it's not going to be different from Malaysia. And for Malaysia, and I think perhaps kind of maintaining existing programs will be, can continue But in terms of either implementing new programs or expanding in a major way critical programs, for instance, self-testing and PrEP. I think those things we are going to find challenges in. Firstly, obviously new programs will require new budgets. Expansion of programs will require new budgets, but also the shifting of attention. And thirdly, those of us who are working in the COVID response are the same people who are working in the HIV response by and large, particularly on the clinical side. And let me tell you, I think all of us who are nodding here are getting exhausted, as the days go on. So those would be the three major factors that I see that would risk current HIV programs, and also in terms of our desire to implement new and expand programs to really end AIDS. I mean, we all know that in Asia and the Pacific, that the HIV response in terms of reaching the 95 goals have somewhat declined after initial good responses, and the targeted reduction, for instance, the targeted reduction in the number of new cases we didn't achieve. I can't remember the exact figure. Was it 500,000? And instead we saw 3 times the number that we promised by 2019. So, even before COVID, we, except for Thailand, Cambodia, and perhaps to some extent Vietnam and Singapore, have nicely reached targets, but Malaysia and the Philippines actually saw an increase in cases. So, so we were already struggling pre-COVID, and so doubling those efforts in the midst of this nasty pandemic is going to be even more challenging.
Michael, you are muted.
I am muted, sorry, apologies. Thanks, Adiba. I want to come back to that point that you mentioned about people working in the pandemic, also the same people working in HIV, and come back to that in a second. After we take this question for Ayu. Ayu, have a question from Rita at the Jakarta Post again. The question is, prior to the outbreak of COVID-19, the COVID-19 pandemic, people living with HIV AIDS face judgmental treatment from the majority of health providers. During this pandemic, it must be getting worse. How do you keep vulnerable people, including women and children and trans people, to get proper medication and treatment during this pandemic? What are some of the things, I think maybe what Rita's asking is, what are some of the things on the ground that you've seen or perhaps have worked in terms of trying to address that issue?
Yeah, thank you, Michael. Thank you, Mbak Rita. So you remind me that I'm not mentioned about the discrimination on the health services to the community of people living with HIV during COVID. That in mostly people living with HIV, we're not really having difficulties because the stigma and discrimination is there far away before the COVID here. But the issue that I heard in the national level, that the discrimination for COVID access is more get by the trans women. So, when trans women get COVID, there are some difficulties and confusion between the healthcare services, the doctor and the nurse, to where to put them. Like they identify themselves as a woman, but physically and as mentioned in the identity card that they are men, so they put in the men room. So it's very inappropriate, and we cannot do anything because it's the government shelter, it's free. So mostly they say that okay, we just deal with it. We all know that mostly our trans women friends is survivor, but I'm very sad about that. And I also listen about her about the stigma and discrimination to people living with HIV friends who access vaccine. So I think it's funny but also sad to hear this because there's it's a big rooms, it's a big place that a lot of people who access the vaccine. You not see one or two people who are they and what are they health their background, but it's because like last 2 months the Ministry of Health trying to help us gather the community of people living with HIV to get especially the person who in the field area who are working in front to get the access first. So we are go to the the healthcare service to get the vaccine together, and we need to mention us as HIV activists, because the Ministry of Health register us with that uh, label, I think. Yeah, for make it easy to us to get access. But when we mention that, the stigma is there, like they suddenly use the hand gloves and double day mask, like, hey, you're not doing that to the person before us. Like, it's very funny. And luckily that mostly the person who got vaccine at the first time is the person who ready to speak up and everything. So either make some noise. We are trying to give education to the person who do the vaccine, that it's okay to give to us. You don't need to very scary about. So if you want to use hand glove, you use hand glove to all of the patient, not only us, like that. So it's, yeah, it's the fact, but luckily they show that to us, so we can give advice to them, and also give advice to the Ministry of Health to teach all the healthcare service person who do the vaccine to do have like some standard operational procedure to uh, the same people who want to get vaccine. So what do I do? Well, actually, I'm not doing this alone. So what do we do is we actually gather. We have the networking of national network from so many organization, like from the women, the LGBT, the drugs user, the sex worker, and etc. So we are like pulling the issue if there is some situation in the field, like stigma and discrimination that increased because of the COVID, and then we used to report to the Ministry of Health because we have that access. So we don't want to make a scene, like either we have to tell to the media about that, we tell them personally, and use because the situation, it's not easy right now. We don't want to make any chaos. So if we can talk to the person who in charge, and then they can fix the issue directly, I think it's better to do without making a chaos. And for the access to treatment, well, it's actually, there's nothing, a lot of change. It's still there, and it's still difficult for the children. As you may, Arita, I think Jakarta Post already know about the difficulties for the ARV situation in Indonesia, for specific for a child. And yes, it's still like that, the condition. We don't have the friendly regimen for children, and etc. And uh, there's nothing we can do right now because the government still not doing anything. We still gather some cases and situation in whole Indonesia, because we have a lot of province, more than 30 province. So we need to have, you know, the real situation to prove that the needs of children living with HIV, you cannot see them as number, you know, cases by cases, because one cases of children living with HIV is you know, it's a someone, you know, it's a child, it's our child. And we help each other, like I mentioned before. In mostly in the big city, there's some outreach worker who help us deliver the medicine, but for specific, the difficulties is more to specific people living with HIV who need another access, like pregnant women who need to, you know, deliver the baby. They have, you know, to do the PCR swab test, who's still which is still very expensive right now, around 1 million. And there's no, you know, the country is not covered for us because we are not COVID patient. We just want to deliver our baby, so we have to pay it by ourselves. So I think that's one of the difficulties also, like when the women living with HIV got violence and we want to access the safe house. Before enter the safe house, we need to do the PCR swab test to make sure that we are negative from COVID, and we have to cover it by ourselves. So what we are trying to do is, you know, if there is a kind of situation like that, yeah, we trying to help us by, you know, make like fundraising to help, let's say for the cases of women living with HIV who want to deliver the baby. So we, you know, we make fundraising for them to get the access of COVID tests. And then also same with other situation. So I think that's all. I hope it answer your question, Rita. Back to you, Michael.
Thanks, Ayu. We have got about 5 or 10 minutes left. I wanted to ask a question to all the panelists. Maybe Vin and Dr. Wong want to start off as well. My question comes back a bit to what Nitya and Adiba were both saying beforehand, and I'm trying to play the optimist here. So my question is, despite the fact that all of you are, you know, working incredibly long hours and are working and dealing with a second surge as well, apart from the HIV work that you do. My question here is, given that we have an HLM on AIDS next week, a UN meeting, looking at targets, looking at progress made, where we're going to go, the impact of COVID, is the current situation where there is so much focus on disease, so much focus on infectious disease, where you could argue that the level of understanding of the public in general across the world is much higher than it would have been pre-COVID in terms of how infection works, infectious diseases, you know, how somebody infected in one suburb can infect somebody else, and in a city and in a country and across countries and so forth. Is it given that that level of understanding of the general public about what a disease can do, an infectious disease can do, compared to the fact that diseases like HIV, generally speaking, TB, for example, are hidden diseases for many people in the West because they're classified as far away diseases because they don't affect people in the West so much these days. Are we perhaps in a situation with a window of opportunity where there is so much focus on disease control, vaccine control, no one is safe until everyone is safe? The same goes to TB, TB anywhere is TB everywhere. Are we in perhaps a window of opportunity as we transition out, I'm being optimistic there, over the next 2 or 3 years out of COVID, do we have a window of opportunity here to convince political leaders about the need to actually end disease everywhere, especially infectious diseases, which have rebound effects from one country, from one part of the world to the other part of the world? Are we in that window of opportunity now to actually leverage things like the ACT Accelerator, which the panel that reported to the WHO a few weeks ago suggested and recommended be taken up for other diseases, not just for COVID? So my question to the panel, starting with Vin and Dr. Wong and then Nitya Adiba, and AU is to get your sense of, can we actually be optimistic given the terrible situation we're at the moment in terms of talking about infectious diseases going forward. You want to start off, Ben?
Hi, Michael. Sure. Well, in the Philippines, pre-COVID, we actually started the Fast Track City programs together with UNAIDS. So I think if we can roll that out in all of the cities in the Philippines and, of course, Asia Pacific, we can actually go and fast forward with the management and eradication of the disease and focusing more on combination prevention. I think it can go a far distance from where we are right now, because I think when COVID came in, the best practices actually halted and everything was refocused. But we also need to take into consideration, I like what you're saying, that you're very optimistic, in a way, thinking that when COVID comes out, or if we are able to manage COVID, just like any other flu there that's manageable, then we can go back to focus on the things that we have left behind 2 years ago. So I think that's one of the keys that we can do, is to encourage and do policy advocacy through Fast Track City programs, so that we can engage local government units and mayors, especially here in the Philippines. The scenario is the Department of Health has decentralized. So we can actually go and partner with local governments and focus and make them realize to focus on specific diseases that were not being provided intervention for previously. So I think, yes, we can do it with the fast track cities.
Great, thank you. Dr. Wong, some brief comments from you too, please.
Yeah, so I think, thanks, Michael. I think those are great thoughts. And I especially like what you said, that, the current, the COVID situation has, I think, hypersensitized a lot of people to what infectious diseases are, to what communicable diseases are. And, I'm always sort of reminded of the fact that many of the breakthroughs that we have in COVID therapeutics, diagnostics, and vaccinology came out of all of the work that's gone into trying to find HIV cure and vaccines over the last, decades. And similarly, I think many of in Singapore at least, there were instances of what we in the HIV world recognized as being infectious disease associated stigma playing out on the COVID sphere, right? People who are infected, people who are possibly exposed, and we saw in that reflections of the experience, anticipated and internalized stigma that people living with HIV have been dealing with for decades. So I think I don't think it's so simple as that COVID we can just wholesale translate or transpose the lessons learned from one disease to another, but I think we can capitalize on the overall atmosphere of increased knowledge, but we cannot do it and hope that this can be achieved passively. I think those of us in the HIV sphere have to breathe down the necks of people in power, and people who hold the purse strings of the nation, that look, these are structures that you put in place that were good for COVID. How can we actually translate them into potentially finding breakthroughs for something that we have lived with for 4 decades? I've got patients coming into clinic asking me, why is it that a vaccine was found for COVID in less than a year? How is it that we've been living with HIV for 4 decades and there's not been a vaccine? How did we discover remdesivir could be so was such a good treatment and we could cure people of it? And why don't we have an HIV cure yet? And those are interesting and colorful conversations, but these are conversations that can't just be held in consultation rooms. I think I'm really hoping that these are conversations that will be held either on the main stage or on the sidelines of the high-level meeting, for example. Thanks.
Great, thank you. Yes, and that point about HIV vaccines, I think one, we have to make very clear scientifically, an HIV vaccine, AIDS vaccine is a bit more complicated than coronavirus vaccine. I think that's one issue, same as TB. But I think it is a relevant issue as well that you know, if perhaps TB had still been around in the first world, you know, in the West, and wasn't just a disease of the poor in parts of Indonesia and in India, would we have got a vaccine earlier? And I think that goes partly to my question, which I'd like to hear what Nitya says and Adiba say about this issue around, you know, not just disease control, but about vaccine control. Will this inspire, for example, vaccine development for a TB vaccine, which we've got, it's 100 years old and doesn't basically work in most people? Nitya?
Yeah, I think those of us, or I have heard or have seen that those of us working in the HIV field, I'm not very sure about the TB field though, have already learned and have taken examples, good examples from COVID to further optimize what we have been doing for HIV already.
Yeah.
I would say, and I don't think that yeah, we may not have to wait until COVID goes away because I don't think many of us would be in the situation that we were forced to only work on COVID, while have to like drop everything for HIV and sexual health. That's my feeling. But at the same time, I also think that there are so many things that COVID should learn from HIV in a way that they have not yet. I mean, they here, it means us as well, now, as part of these COVID responses. We have not yet really brought together experiences and lessons learned from the HIV field, the 40 years of HIV, into this like year 2 of COVID-19. So for example, I already mentioned the community-led, the people-centered approach, because it will not be just like a month from now that COVID will end. If you don't start addressing the problems in a client-centered and community-led approach, then you will like control this wave, and then another wave comes back again and again and again. That's one thing. And the second thing is the differentiated service delivery. I feel that this is so important, especially for low and middle income country, where we don't we will never be able to afford like PCR for everyone, and we will not be able to afford the hospitalization of every confirmed COVID cases. Those are what Thailand is currently doing, and then it like leave people who has not yet been diagnosed and who are diagnosed but could not get hospital beds, dying outside of the hospitals. And I think that this is really something that every country can learn and adapt right away.
Thank you. And of course, we shouldn't forget that, you know, we probably wouldn't have the COVID vaccines if it hadn't been for the HIV research into a vaccine as well. And it's been well documented by Dr. Fauci too, about the early work, the work that has gone on to find an AIDS vaccine has been quite instrumental in some of the COVID vaccine research as well. Adiba?
Yeah, Michael, I think, you know, especially at the beginning of the pandemic, we had suddenly armchair epidemiologists, and everyone knows what a PCR is and an R0 is, and you know, it was pretty interesting to watch. But like you said, we definitely should take this opportunity, you know, and you know, with a focus on global health and on infectious diseases and communicable health, you know, call for increased attention to you know, not just pandemic preparedness, but also in kind of working not in, like you said, not in disease specific manner, but in a more holistic manner. You know, TB and COVID and HIV, you know, in places like prisons and all that are all intertwined. So integrating treatment services in focusing on patient and population-centered care should be accelerated post-COVID. Secondly, I think many of the things that have enabled us to get to where we are now with the COVID response compared to, you know, the delay in the HIV response. Okay, we didn't have as much science there, but the platforms, the network, the ease by the relative ease by which people were happy to collaborate for a common good. I think those are some of the changes that hopefully will be permanent. We scientists can be selfish, and so that data sharing and all of that, that open science, I hope moving forward will be something that will become more of a norm, and not just now for us to respond to COVID. So I think those are some of my thoughts on what you've just said, because I completely agree with what everyone else has said here too.
Great, thank you. And I think with that, we've run over time. I think we're going to have to wrap it up there. I'd like to thank all the panelists today for their thoughts and insights. And for all the journalists sitting out there, thank you very much for being here today. As I said before, if you want, we will send you the recording in a few hours. And if any of you do want to speak to any of our speakers one-to-one, please let me know directly. You've all got my email address, and we'll do our best to do that today going into Monday as well. Thank you very much, and have a good weekend.
Bye everyone, thanks.
Bye.
Thanks, bye.
Thanks, everybody.
Bye, everyone.
Bye.
Thank you so much.
Thank you.